Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent funding from Novartis.
Hello, I'm Gabby Hobbs. I'm an associate professor of medicine at Harvard Medical School and clinical director of the Leukemia Service at Mass General Hospital in Boston. Welcome to this program titled Chronic Myeloid Leukemia, a 2024 update on novel targets and recent clinical data. So in the United States in 2024, an estimated 9,300 people were diagnosed with CML, and CML led to 1,280 deaths. The introduction of imatinib greatly improved CML survival, and today over 90% of patients will survive 5 or more years after diagnosis. As a result, more people in the United States are now living with CML. An estimated 150,000 people, projected to increase to as many as 450,000 people around 2040 to 2050. Central to the pathogenesis of chronic myeloid leukemia is a reciprocal translocation of specific DNA segments between chromosome 9 and chromosome 22. Chromosome 9 contains the Abelson-Murin leukemia gene, ABL1, which is a proto-oncogene that encodes the ABL protein. This protein plays a crucial role in regulating various cellular processes, including cell adhesion, proliferation, differentiation, survival, and migration. Chromosome 22 contains the breakpoint cluster region, or BCR, which produces the BCR protein, whose function is not fully understood. During the translocation, the 3' end of the ABL1 gene detaches from chromosome 9 and joins the 5' end of the BCR gene on chromosome 22. This genetic rearrangement is known as the Philadelphia chromosome, which results in the formation of the chimeric oncogene BCR-ABL1. The BCR-ABL1 fusion gene encodes the BCR-ABL1 oncoprotein, constitutively active tyrosine kinase that relocates itself to the cytoplasm of the cell. This is the linear structure of the P210 isoform of the BCR-ABL fusion protein that leads to the development of CML. It includes the first domains from the BCR sequence, plus all the domains from the ABL1 sequence except for the N-terminal cap of the SH3, which is important for autoinhibition of ABL1 kinase. In the fusion gene, the coiled cap domain from BCR facilitates dimerization and autophosphorylation of the BCR-ABL1 protein. The ABL1 kinase of the fusion protein becomes hyperactive and starts to phosphorylate various substrates. This leads to direct and indirect activation of multiple signaling pathways downstream, including PI3 kinase, mTOR, MAP kinase, and JAK-STAT. The net effects of this signaling include unchecked proliferation, inhibition of apoptosis, and migration of CML precursor cells, as well as increased genomic instability. The FDA has approved 5 tyrosine kinases for newly diagnosed CML. The first one to be approved was imatinib in 2002, and that is the only first-generation TKI. There are 3 second-generation drugs, dasatinib, nilotinib, and bosutinib, and more recently, we have Asciminib approved in 2024. The orthosteric TKIs, also known as the ATP binding pocket TKIs, include imatinib, dasatinib, nilotinib, and bosutinib. Orthosteric means that they bind to the active site of the BCR-ABL1 protein kinase, which is the ATP binding pocket. ATP is a molecule that activates many proteins, including BCR-ABL1. It does this by binding to the ATP binding pocket on the kinase domain of ABL1. Once activated, the kinase transfers a phosphate group from ATP to the tyrosine residue of a bound substrate. This causes structural changes to the substrate and converts ATP into ADP. ADP and the phosphorylated substrate then detach from the kinase. As ADP goes off to get recycled back into ATP, the phosphorylated substrate recruits effector proteins to activate downstream signaling transduction pathways that promote CML proliferation and survival. Orthosteric TKIs like imatinib, dasatinib, nilotinib, and bosutinib compete with ATP for the ATP binding pocket on ABL1. By binding to the pocket, the TKI prevents phosphorylation of the substrates and activation of the signaling pathways that drive CML. The conformation of the ATP binding pocket at a given time depends on whether ABL1 is active or inactive. Imatinib and nilotinib are structurally similar and can only bind when ABL1 is inactive. Dasatinib and bosutinib are structurally distinct from imatinib and preferentially bind to the kinase when ABL1 is in an active conformation. Although nilotinib, dasatinib, and bosutinib are more potent than imatinib, long-term follow-up from phase 3 first-line studies has shown no significant difference among them in terms of overall survival and progression-free survival rates. The second-generation ATP-competitive TKIs do appear to produce earlier deep molecular responses, or DMRs, than imatinib. Here's a summary of some of the outcomes across first-line therapy for CML. And you can see that when comparing the second-generation TKIs to imatinib, they all lead to higher rates of EMR, or early molecular response. This is a change in the BCR-ABL at 3 months, as well as greater levels of MR4.5, with similar rates of these molecular remissions with dasatinib compared to nilotinib. And really, there's only been a few studies comparing head-to-head second-generation TKIs. JLG-CML 212 randomized dasatinib versus nilotinib for newly diagnosed CML. So in 2024, the 36-month follow-up of this study was published, and there was no significant difference between treatments on any efficacy endpoint at 36 months. So EMR rates, major molecular remission rates, MR4, MR4.5, and cytogenetic remission rates were similar, as well as time to first cytogenetic remission. Progression-free survival, event-free survival, and overall survival rates were the same with both drugs, including when they were stratified by different risk scores. An important study to highlight as well is low-dose dasatinib in newly diagnosed CML. 83 patients with newly diagnosed chronic phase CML received dasatinib 50 milligrams per day. At a median follow-up of 5 years, the MMR rate was 95%, with an MR 4.5 rate of 82% and a CMR of 70%. The overall survival at 5 years was an impressive 98%, and there were no cases of CML in accelerated phase or blast phase. Only 5 patients, or 6% of the population, changed to other TKIs for possible suboptimal response or resistance. Now let's talk about Asciminib. So Asciminib is the most recent TKI approved for the treatment of CML. It was approved in 2021 for relapsed or refractory CML, and it received accelerated approval in October of 2024 for newly diagnosed CML. Asciminib is an allosteric STAMP inhibitor. Allosteric means that it binds to the kinase somewhere other than the ATP binding pocket. The native ABL1 kinase has a myristoylated N-terminal cap, which is essential for autoinhibition. The N-terminal binds to the myristoyl pocket of the kinase domain to lock ABL1 in a closed, inactive state. When BCR fuses to ABL1 on chromosome 22, it replaces the N-terminal, resulting in the constitutively active BCR-ABL protein. The myristoyl pocket is retained on the ABL1 kinase. Asciminib specifically targets the ABL1 myristoyl pocket and is described as a STAMP inhibitor. By binding to the myristoyl pocket, Asciminib restores autoinhibition and prevents downstream oncogenic signaling. ASC4FIRST was the phase 3 study of Asciminib versus investigator-selected tyrosine kinases in newly diagnosed CML. This study included patients with chronic phase CML with no prior therapy that were greater than 18 years of age. Patients were randomized to receive either imatinib or a second-generation TKI, and then they were randomized to receive either Asciminib once daily versus imatinib or second-generation TKIs. The primary endpoint of the study was MMR at week 48 for Asciminib versus all investigator-selected TKIs, and MMR at week 48 for Asciminib versus investigator-selected TKI within the imatinib stratin. Previously, reported outcomes showed significantly higher MMR rates with Asciminib at 48 weeks, compared with all investigator-selected TKIs. At ASH 2024, the MMR rates at weeks 96 were presented, as shown in this slide. Asciminib compared to second-generation TKIs led to numerically higher rates of MMR at week 96 compared to second-generation TKIs. So one of the things that we need to consider is what is the relationship between achieving major molecular remission and survival? So we know that achieving a cytogenetic response at 1 year is correlated with improved overall survival. However, we don't have those data for deeper remissions in terms of survival. So when we look at studies like the Ask for First study demonstrating improved efficacy of Asciminib compared to all TKIs, but in particular to imatinib, one has to wonder, how do we think about these data in selecting Asciminib in first line? So this study showed without a doubt that Asciminib leads to improved rates of major molecular remissions compared to imatinib, but only numerical improvement in MMR compared to second-generation drugs. But these data still do not show us two main important endpoints that we care about, which is, does the use of Asciminib in first line lead to higher rates of treatment-free remission compared to the other TKIs? And does the use of a drug like Asciminib improve overall survival or progression-free survival? To answer those questions, we're going to have longer follow-up with Asciminib. Now, one thing to consider is that Asciminib is also a very well-tolerated agent. But we have to balance that also with the fact that we have other TKIs that have a longer track record, some of which are now also generic. And so the cost of treatment also needs to be considered when making decisions about first-line therapy. So let's discuss resistance mutations. Resistance to first and second generation ATP-competitive TKIs is primarily due to point mutations in ABL1 kinase that cause steric hindrance. In other words, changes to the structure of the ATP binding pocket or prevention of chemical reactions. Resistance-causing mutations are especially frequent with imatinib. T315I, also known as the gatekeeper mutation in the ATP binding pocket, is the most common resistance mutation and confers resistance to imatinib, dasatinib, nilotinib, and bosutinib. Asciminib is effective against CML with the T315I mutation, but mutations in the myristoyl pocket may also confer resistance to Asciminib. Ponatinib is an ATP-competitive TKI designed to overcome the T315I mutation and also appears to overcome single resistance mutations. Ponatinib was initially approved for patients with T315I mutations and no other TKI option. But cardiovascular toxicities, including arterial occlusive events, emerged with the standard 45 milligram dose. In order to mitigate these toxicities, the Phase 2 OPTIC trial implemented a response-based reduction strategy in patients with chronic phase CML resistant to greater than 2 TKIs or those with a T315I mutation. 60-month outcomes were presented at the ASH annual meeting. Looking at the different efficacy with ponatinib started at the dose of 45 milligrams and then reduced to 15 milligrams when patients achieved an MMR, and then when patients were started at 30 milligrams and then decreased to 15 milligrams, or for those patients that were started at 15 milligrams and remained at 15 milligrams. So 60% of patients in the 45 milligram cohort, 41% in the 30 milligram cohort, and 40% in the 15 milligram cohort achieved a BCR-ABL of less than 1%. And the median duration of MMR was not reached in any cohort. Here we're showing the progression-free survival of patients treated on the OPTIC study. The median overall survival was not reached in any cohort. 5-year overall survival was across all 3 dosing groups. And so these results are significant because it demonstrates that dose reduction based on response is safe and also efficacious. So in this slide, we're demonstrating the adverse events by exposure depending on the different group that patients were started on. And we can see that the grade 3-4 treatment emergent adverse events were similar for all three groups. Now let's talk about bosutinib in previously treated CML from two different studies, the BODO study as well as the BEYOND study. Sub-analysis of the phase 2 BODO trial was presented at ASH this past year. Of 45 patients previously treated with nilotinib or dasatinib, 2/3 were able to achieve an MMR during treatment with bosutinib. The phase 4 BEYOND trial final analysis was also presented. This trial included 163 patients with greater than 3 years of follow-up. They demonstrated that MR rates deepened from baseline in most patients. 81% of patients attained or maintained a complete cytogenetic remission during treatment, and 71.8% attained or maintained an MMR. Importantly, no new safety signals were identified. Most patients who had dose reductions maintained their response for greater than 6 months. Ask to Escalate is also another study that was presented utilizing Asciminib, in this case in second-line chronic phase CML. The key inclusion criteria for this study was that patients needed to be greater than 18 years of age with chronic phase CML, without a history of accelerated or blast phase disease, and without a T315I mutation. For the second-line cohort, patients needed to either have a warning or failure in response rate per the ELN 2020 with first TKI at the time of screening, or they had to have intolerance of first TKI and a BCR-ABL of greater than 0.1 at the time of screening. So for this study, patients were given Asciminib 80 milligrams daily, and they could escalate the dose of Asciminib if they did not have an optimal response. The primary endpoint of the study was MMR at 12 months in the second-line cohort. And here we're demonstrating the molecular response in patients with adequate follow-up, showing that at week 24, there were really impressive MMR rates as well as BCR-ABL rates of less than 1%. So among the evaluable patients at week 24, baseline BCR-ABL levels were greater than 10% in 8 patients, greater than 1% to less than 10% in 9 patients, and greater than 0.1% to less than 1% in 11 patients. Most patients had a BCR-ABL level of less than 1% at week 24, which is considered an optimal response, and dose escalations from 80 milligrams daily to 200 milligrams daily occurred only in 2 patients, one in week 24 and the other in week 48. An important aspect to consider in terms of therapy selection is the adverse events of the different TKIs. So for imatinib, some of the common side effects that we see with this drug include peripheral edema as well as periorbital edema, myalgias as well as GI disturbances. Sometimes patients can have elevation in creatinine, decrease in their phosphorus, transaminase abnormalities, as well as decline in their GFR. When thinking about second-generation TKIs, for dasatinib, pleural and pericardial effusions can be common, occurring in up to 1/3 of patients and can be delayed. Bleeding, especially when starting therapy when patients are thrombocytopenic. Rarely, patients can also have pulmonary hypertension, and sometimes patients can also have GI disturbances, especially when starting therapy. Nilotinib is associated with cardiovascular adverse events, including worsening of peripheral vascular disease, worsening of hyperglycemia, QT prolongation and arrhythmias, as well as elevations in bilirubin. Bosutinib is associated with GI toxicities being the most significant, especially at initiation of treatment, but is usually something that improves over time. Bosutinib is also associated with elevations in transaminases, as well as with declines in GFR, but this is rare. In terms of third-generation TKIs, ponatinib is associated with significant cardiovascular toxicities, including heart failure, arterial and venous thromboembolic complications, pancreatitis, hypertension, and peripheral arterial disease. Asciminib is generally well tolerated and has been found to lead to elevations in lipases, though this has not led to increases in rates of pancreatitis. Sometimes patients may have arthralgias, headaches, GI disturbances, although this tends to be mild, and cardiovascular toxicity mainly in the form of hypertension, but there haven't been elevated rates of peripheral arterial disease. The adverse events of the drugs are important when considering switching therapy. So one can consider switching to an alternative TKI for the following non-hematologic adverse events. So if patients have arterial and vascular adverse events, that is an important reason to stop that medication and switch, and this occurs more commonly with nilotinib and ponatinib. Hypertension that is not responsive to antihypertensive medications is a reason to also switch, and this is particularly relevant for patients on ponatinib and Asciminib. If a patient develops pulmonary hypertension, or if a patient has pulmonary hypertension in general, dasatinib is probably not the right treatment for them. If a patient develops recurrent pleural and pericardial effusions despite dose reduction with dasatinib and less frequently with bosutinib, that would be a reason to switch therapy. Nilotinib, ponatinib, and theoretically Asciminib can lead to recurrent pancreatitis or pancreatitis in general, and so that would be a reason to stop the medication and switch to something different. If a patient has hyperglycemia that is not well controlled, or if a patient develops hyperglycemia while on nilotinib, that would be a reason to consider discontinuation. If a patient has persistent moderate to severe nephrotoxicity, unfortunately, this can occur with all of the TKIs, although it's worth noting that this does not occur that frequently. LFT abnormalities can occur with all the TKIs, but are more common with bosutinib and imatinib. GI bleeding rarely occurs with dasatinib, and this is particularly relevant at the beginning of treatment when a patient develops thrombocytopenia because of treatment, but it rarely occurs later in treatment. So if GI bleeding does occur, it's important to rule out other etiologies for that, as that's more likely the culprit. Immune-related adverse events, for example, colitis, pneumonitis, hepatitis, myocarditis, pericarditis, and nephritis, could potentially occur with all of the TKIs, although this is pretty rare. In general, when talking to patients about receiving treatment for their TKI and successfully maintaining patients on therapy, it's important to counsel patients on the risk factors for cardiovascular disease, as well as ensuring that these risk factors are well managed either by their primary care doctor or cardiologist, as increased cardiovascular complications can occur with long-term therapy with TKIs. When patients are first starting therapy, growth factor support can be considered, although generally this is pretty rare. And it's worth noting that if somebody is already in remission and on long-term therapy with a TKI and they develop cytopenias, it's important to evaluate why this is happening, as generally patients that are on a stable dose and with good control of their disease should not develop new cytopenias on treatment. But this is pretty common when patients first get started on therapy. When monitoring a patient with CML, it's important to be aware of the criteria for response as well as for relapse. And the NCCN guidelines really are very helpful in order to ensure that a patient is achieving these different milestones. So the first milestone that one needs to target is the achievement of a complete hematologic remission, which basically means a sort of normalization of the CBC. And this needs to occur in the first 3 months of therapy and does occur for most patients. A cytogenetic remission means complete cytogenetic response, where no Philadelphia chromosome metaphases are seen on cytogenetics. And then there are different criteria for major cytogenetic response, partial cytogenetic response, and minor cytogenetic response. It's worth mentioning that for patients that are achieving molecular responses, we really rarely monitor cytogenetic responses anymore, and we rarely, if ever, recommend following responses with serial bone marrow biopsies, as molecular responses are excellent surrogates for response that can be done from the peripheral blood. So the more important response to monitor truly is the molecular response. So an EMR, or early molecular response, means that the BCR-ABL transcript by the international scale has decreased from starting levels to less than 10% at 3 months and 6 months. Major molecular response, or MMR, means a BCR-ABL of less than 0.1%, or a 3-log reduction of the BCR-ABL transcripts from the beginning of therapy. And deep molecular remission, also known as MR4, is a BCR-ABL of less than 0.01%. MR4.5 is a BCR-ABL of less than 0.0032%. A PCR of less than 1% at 1 year is considered equivalent to a cytogenetic response. And if patients are meeting those molecular criteria, there's no indication for repeating a bone marrow biopsy and confirming the cytogenetic response from the bone marrow. Now, what is considered relapse? So any sign of loss of hematologic response, any sign of loss of complete cytogenetic response, which correlates with an MR2, or a BCR-ABL level, like I mentioned, of less than 1%, and any 1-log increase in BCR-ABL transcripts with the loss of MMR. So if a patient goes from 0.001 to 0.01, even though that's greater than 1 log increase in their BCR-ABL, that is not considered relapse. Now, if the increase means that the patient loses an MMR, then that is considered relapse, and that is a reason to be concerned. So it's also important to monitor response to TKI therapy and also keep in mind mutational analysis and when to do that. So in terms of how to follow patients, initially when somebody gets started on therapy, it's important to do CBCs every 1 to 2 weeks for the first couple of months until they have a normalization of their blood counts. And it's also important, I think, personally, to check in with those patients frequently at the start of therapy to ensure that they're tolerating treatment well and that they're receiving supportive care in order to tolerate the initiation of their TKI. With regards to bone marrow cytogenetics, I usually only do this at diagnosis and in patients that have relapse disease and for whom they do not meet the milestones of treatment. But generally speaking, most patients can get away with only having a bone marrow done at diagnosis, and then it does not need to be repeated. PCR testing needs to be done at diagnosis and then every 3 months after initiating treatment and until a patient achieves a PCR of less than 1%. Generally, we do a PCR every 3 months for the first 2 years of therapy, and then they can be done every 3 to 6 months after that. For patients that do not have optimal responses, for patients that present with accelerated or blast phase disease, and for patients that lose response, it's important to perform an ABL1 kinase domain mutational analysis to see if we can identify mutations that may guide our treatment. The NCCN guidelines is also very helpful for us to ensure that patients are meeting their treatment response milestones. And here is a summary of the chart that is found in the NCCN guidelines, where patients that are in red have TKI resistant disease, and in yellow they have possible TKI resistance. In orange, again, also possible TKI resistance. Light green indicates TKI sensitive disease, as well as green. And really, we're trying to ensure that patients are being properly evaluated in order to make sure that they meet their milestones and have as optimal as possible overall survival, and that patients are selected properly for discontinuation of therapy. So for those patients that do not have an adequate response, that have accelerated or blast phase disease, or that have had a molecular relapse, the NCCN guidelines has sequencing based on these mutations. So if the mutations are identified, then we can make treatment decisions to ensure that we choose a TKI that is sensitive to that mutation. So now an important part of the management of CML patients is treatment-free remission, or the discontinuation of TKIs. And there have been multiple studies that have confirmed the safety of this approach. So the EuroSki study was a study looking at treatment-free remission, and the final analysis was recently presented. And so this study included adults with chronic phase CML receiving a TKI for greater than 3 years with a confirmed deep molecular remission. 61% of patients achieved the primary endpoint of molecular relapse-free survival at 6 months. 46% of patients achieved molecular relapse-free survival at 36 months, and the 3-year overall survival for these patients was 98%. When loss of MMR did occur, within 6 months, the probability of recovery of MR4 was 28% by 3 months, 71% by 6 months, and 85% by 12 months. When loss of MMR occurred at greater than 6 months, the probability of a recovery of an MR4 was 52% by 3 months, 92% by 6 months, and 96% of 12 months, confirming the safety of this approach. Duration of TKI treatment, percentage of blasts in the peripheral blood, and transcript types were the best predictors of MMR maintenance. So in addition to the available TKIs, there are also novel TKIs that are currently being developed, and on this table, I show a few of the TKIs that are being developed. There's oliverbaptamib, that's an orthosteric inhibitor that's being evaluated for patients that have been treated with greater than 2 or more TKIs. There's also TGRX678, which is a STAMP inhibitor that's being developed in several different lines of therapy. And then there's flumatinib, a second-generation orthosteric TKI. So take-home points. In general, TKIs have greatly improved outcomes for patients with CML, with overall survival now being similar to the general population. Resistance can occur with long-term use of ATP-competitive TKIs. However, this is still rare. The approval of The first STAMP inhibitor, a class of drugs that inhibit the BCR-ABL through selective binding of the myristoyl pocket, is a welcome addition to the armamentarium of CML. It offers patients with point mutations that alter conformation of the ATP binding pocket another effective option with the potential for fewer off-target effects. Additional STAMP inhibitors are in development for CML. Mutations that confer resistance to STAMP inhibitors are emerging, however, and studies are looking at combining orthosteric as well as allosteric TKIs in order to overcome these mutations. Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.